No, this is the starting slide.
Right, Dr. Amarjit, if you can
Yeah.
just go back. Yeah. Just hold on this slide.
This slide is good for waiting.
Yeah. So I think we should start.
Yes.
Just a moment.
Which one we are recording this, right?
So I think we should start.
Yes,
And we are
recording
live as
is
well.
on.
And we are live as well.
Good evening.
We are recording this, right? Yes.
Good evening, ladies and gentlemen. This is Dr. Amarjit Singh, a medical member from the Wockhardt. A very warm welcome to all of you in the iTrust webinar on barriers to initiate insulin therapy. We are honored to have a distinguished speaker, Dr. Uttara, with us today, who will shed a light on the crucial topic that affects millions of people worldwide. Initiating insulin therapy is a significant step in the management of diabetes, and it can have a profound impact on the lives of those living with this condition. However, despite the clear benefits, there are numerous barriers that often hinders the timely and appropriate initiation of the insulin therapy. Today, we are fortunate to have an expert who will share insights, knowledge, and strategies to overcome these barriers. Our esteemed speaker is an authority in the field of diabetes management, renowned for her clinical expertise and dedicated to improving patient care. Dr. Uttara is currently a senior consultant at Dr. Mohan's Diabetes Specialties Center at Chennai. She has 18 years of experience in the field of diabetology with special interest and expertise in pregnancy and diabetes. She has been awarded the Youth Leadership Award 2021 for excellence in the diabetology. She obtained her MBBS from Sri Ramchandra Medical College and Research Institute, Porur, Chennai. She completed her fellowship in diabetology, November 2007, from Dr. Mohan's Diabetic Specialties Center and Research Institute. So before we proceed, I would like to express our gratitude to all the participants for joining us today. Your presence reflects a commitment to advancing diabetes care and improving patients' outcomes. Without further delaying, I will invite our distinguished speaker to take the virtual stage. Ladies and gentlemen, let us welcome with great enthusiasm of Dr. Uttara. So over to you, madam.
Thank you, Dr. Amarjit, for that kind introduction. Good evening, all, and indeed a great pleasure to address you all on this pleasant evening from Chennai. And thank you, Wockhardt, for this wonderful opportunity. So, as Mr. Amarjit did, Dr. Amarjit did say, I don't want to, without much ado, I will go directly jump into the topic for today. And 100 years of insulin, I think this topic would never go out of, it'll always be on the trend. So today's topic is going to be benefits of early insulin initiation. So this will be my agenda for the day. So I'll talk to you a little bit about the burden of diabetes, which you're all very well aware, and the barrier to insulin initiation, what is the current perspective on the same. And we'll also look at the adherence and the barriers or the root cause analysis, how we can tackle it, and clinical pearls of wisdom for addressing the barriers to insulin initiation. So the problem and the solution, that's what we're going to look at today. And
I request to keep on the presentation mode.
Oh, it's not on slide share mode. Sorry.
Yeah, thanks.
Okay. So recently we had, we knew that, we had the dubious privilege of being called the most populous nation in the world. So with that comes all the other, we'll soon become the diabetic capital of the world also, because our population is rapidly growing. And, compared to China, we have the younger population. China has more of the elderly population. So, and, we're already the pre-diabetes capital, and we're going to soon be the diabetic capital, no doubt at all, with the growing number. And, sometimes the predictions are also, we're outrunning the predictions itself these days. So almost around 1 in 7 adults have diabetes. That is 74.2 million people have diabetes. Or that's actually the size of almost some of the continents itself. Now, the people die from diabetes-related causes. So just not the numbers increasing. Are we doing a little better with the quality, at least, of the quality of care, with so much of infrastructure improvement and so much of technological improvement, AI coming in, and so much happening in the medical field? Are we actually, at least, even if the numbers are increasing, are we handling it better? No, the sad story is no. The numbers are increasing, and so are our comorbidities and complications, which are also equally, exponential growth is seen in that direction also. And you can see that how many mortality rate is quite high with diabetes, with the cardiovascular disease being the numero uno cause of death from diabetes, and more than 53% of people with diabetes are undiagnosed. So there are almost around 39.4 million people who are like a time bomb ticking. So the 10 billion is the annual diabetes related expenditure, and yet with so much expenditure, yet we have not reached, the optimal control we should be offering our patient. And the current status of management, control, complications, psychological aspects from the Diabcare India, from my own center, published by Dr. V. Mohan et al., showed only 19.7% of people with type 2 diabetes had an A1C of less than 7. So only with so much available, so much awareness, so much CMEs happening, and camps happening, and WhatsApp messages, Facebook messages, and so many social media messages, yet only 19.7% of the people are able to reach their target. And the BMC, the global scenario, is also not very different. Only 23.4% of people with type 2 diabetes have an A1C of less than 7. What are the factors which are affecting it? Is that almost only 16.3%? It is data from the South Asia, the CAST trial. Again, we were part of that also, and which showed, the percentage is only very, very minimal. So despite all the benefits of good glycemic control, all of us being convinced about how an optimal control should be, and all of us treating our patient to the best of our effort, till the target levels are not met, which is called the diabetes inertia or the therapeutic inertia. Now, the overall area-wise weighted prevalence of diabetes, so it's not very different all over the nation. It is not much of a huge difference, one country doing better than the other or so on. Almost we are in the similar platform. But the thing is, the ICMR India published from by Dr. Anjana Mohan et al. Also showed that, the NCD's risk, not just diabetes, the overall NCD's risk is also growing quite high, and more investigating, and more people are diagnosed with, you get them higher reds and so on. This is diagnosis by means of OGTT. That is, not everybody has access to oral glucose tolerance testing. So even by means of HbA1c, the recent ADA guidelines and all that did say you can diagnose diabetes by A1C levels also about 6.5 and 2.1, almost 13.3% had. And if you had to do a combination like in a tertiary center or a proper diabetes clinic or endo clinic, you will do a OGTT and a A1C, and a combination of these two, 21.1%. So the prevalence of diabetes and other metabolic NCDs in India is considerably higher than what it was previously estimated and also what it was previously predicted. You know, that the mathematical predictions of this much percentage increase and all that, we're kind of outnumbering that, and we're really missing out somewhere that the growth is so exponential. So let's look at what are the barriers to insulin initiation. And why are we talking about insulin initiation? Because to get an optimal control, we have to give the best of care. So when we have so much in our armamentarium, and is there still a need for insulin, or are we really using this 100-year-old tool properly, or are we still lagging behind? Is the inertia so huge? This is the judicious use of anti-diabetic medication. This is adapted from the 1999 paper where, January 2013 paper, which looked at different meta-analysis, actually meta-analysis of multiple papers, where they looked at the prescribing pattern of medications in terms of OHAs, GLP-1 analogs, insulin, and so on. So that when you look at the percentage of prescription and how much of the change in insulin was compared, change in A1C was compared, and you can see with GLP-1, the A1C reduction is 1.12, 0.74 with BP4. AGIs had a 0.72, TZT 0.9, sulfonylurea 0.7, glycine 0.6, metformin 1.21. Obviously, all this we're talking about in a naive patient, treatment naive patient, whereas the best A1C reduction was seen with insulin 1.22, 1.08, 1.91, and 1.28 in basal bolus prandial premix and basal regimens of insulin initiation. SGLT2 also has almost around 0.74. So you can see as a class, insulin was way ahead of any of the OHAs which are available in our armamentarium, almost around 1.5 to 3.5% reduction. So, you know, the higher the A1C, the better the reduction. So a patient comes in with 11 or 10 A1C, especially glucotoxicity and so on, insulin initiation would definitely bring down the HbA1c by even 3 to 4%, which we had seen in many of our clinical scenarios. So insulin offers the maximum glycemic efficacy, and almost all of us are convinced with this fact. There are enough data over the 100 years, enough evidence, robust evidence is available to prove the fact that so far available, most efficacious in our armamentarium is insulin. And yet, why do we physicians or diabetologists or endocrinologists have this inertia for initiating? Or where is the barrier? Is it only from the physician or the medical point of view, or is it from the patient point of view, or it's a cluster of many factors? Now, looking at the Indian perspective, the glycemic control and delayed initiation was looked at. This is the Indian study published, which looked at, as a monotherapy, dual therapy, triple drug, and more than 3 drugs. So when do they really initiate insulin? So most of the time, if you see, there are delayed periods of hypoglycemia. Only then it is most of the time, earlier insulin was used as a threatening tool, kind of, I'll add on another OHA. If that's not going to work, maybe I'll have to think of insulin. And I'll add on another OHA, a third one. If this is not working, maybe I'll have to think of insulin. It's like a threat. When earlier years, it was used as a threatening tool. If the sugar doesn't come down, maybe I have to think of insulin. So the tone with which we, discuss with our patients about insulin itself create this stigma. And many of the places, many of the prescriptions, if you look at, they have very prolonged periods of suboptimal control only after second drug, third drug, and sometimes even fourth OHA. Only then insulin is sought after. And remember, all through this third, fourth, and all through this period, the HbA1c had been on a very poor control. And we know if you're not able to control the A1c in the first few years of diagnosis, this will have a high negative legacy impact on our complications in our patient. So this also has to be considered. So delayed insulin initiation, often beyond 10 years, of having poor glycemic control. Look at it, 0 to 5 years, 5 to 10 years, 10 to 15 years, 15 to 10 years. The average time when insulin is thought of or initiated is like when it is kind of burnt out. It is not thought of when the sugars are suboptimal. It is thought of only at around 15 to 20 years or 20% LTDs, long-term diabetic population. Only then insulin is sought out in many of our Indian population. So insulin initiation is often delayed in routine clinical practice. Now, there is definitely a need for early and intensive approach to type 2 diabetes management. So what is the problem? Where is the problem? This is called the clinical inertia, the cluster of clinical inertia, or the barrier to early insulin initiation. Now, there is lack of appropriate education. The word appropriate should be enforced because there is a lot of education, and a positive education and negative education. Recently there was some doctor who said seven keeping HbA1c less than 7 is not necessary. Also, all doctor herself said they are initiating insulin unnecessarily and so on. This will have a much higher impact than you and me talking to our patients about good legacy and good glycemic control. So so much of misinformation also. So appropriate education is missing, and the patient perception of insulin treatment and outcomes. Perception, it's not from the doctors alone. My neighbor had insulin and then she had this problem. My grandmother had insulin, after that she expired. And there's so much conspiracies which come tagged with insulin is so high. And of course, the real and practical barrier is hypoglycemia. When during the initiation phase and the adjustment phase, even during clinical trials and so on, when there is a, in a controlled environment itself, hypoglycemia is a risk. So when you do not have a controlled environment like a clinical trial, so I'm initiating insulin, I'm not admitting the patient comes back to me after about a month or two, definitely there will be ups and downs. And that is a very big barrier. And of course, the quality of life, carrying the pen or the vial and taking insulin in front of people, the stigma involved in it, taking it, transportation and so on. All this can lead on to lack of patient adherence to treatment. And there was also a concept that when I started insulin and I started consistently gaining weight and so on, where we do try to explain, even in the good old UK PDS trial, where the intensive arm had the only insulinization. The intensive arm was highly the basal bolus or a premix regime of very high dose of insulin. Even in that, over a period of a year, there was only 3 kg weight gain. So, but still, every month gain is related to insulin. There will be a minimal weight gain. No, we cannot disagree with it, but you can't blame all the weight on insulin. And of course, the complex regimes, you're going to give some type 2 diabetic. We're talking about type 2 diabetic, a basal bolus regime along with OHS is going to be a little complex for them. And of course, risk in patients with comorbidities, have some retinopathy or neuropathy with tremors or have a Parkinson's or living alone and so on. There is some practical complications also in initiating of insulin. Resource issues are there, and beliefs about patient competence and financial restrictions. A lot of these things play a huge role in the being an obstacle to initiation of insulin. Now, from the patient point of view, patient barrier, attitudes among patients willing or unwilling to accept insulin therapy. This is a concept that, once you start insulin, lifelong, you get addicted to insulin. They use that word, if you're going to start insulin, won't it form a habit? That kind of questions, and I do tell them that you have to think about only bad habits like, smoking and alcohol and so on, not about insulin. But still, there are times when we can explain to them about temporary insulin initiation, like breaking down the glucotoxicity, trying to bring down. And there are a lot of stories of reversal of, diabetes also with early initiation and so on. So it's not in every patient, but, insulin is not a rule to be continued lifelong. So explanation, educating the patient one-to-one would go a long way in impacting this barrier. Patients care, not good enough, not confident with the therapy, problematic hypoglycemia, anticipated pain from injection, lack of fairness, life will be restricted, feeling that my diabetes will be more serious. Yeah, that's the common thing. They think nothing works, doctor. I have a last resort. Insulin is the last resort. Can we not try something else? That kind of concept, that is partly even the medical fraternity are at to blame. Insulin causes problems like blindness and so on, and is seen as sick, weight gain, injection fear, less flexibility, and diabetes is worsening. So all these are the patient point of barriers, insulin among treatment naive or experience. Now, the perceived burden of treating diabetes in experienced and inexperienced persons. If you see people who are already on it, so this is a survey done by Vijayan et al. And he looked at whether already on insulin or newly introduced insulin, how is it? So if you look at the lowest burden and the greatest burden rating with the experience, and insulin 3 to 4 times the burden is the higher, whereas 1 time it's less. But once a day, again, least experience consider that itself as a burden. So the blue ones are with experience and the green ones is without experience. So if you put it under different permutation and combination, still insulin is considered as a huge burden with or without experience. But the simplifying the regime would definitely go a long way. Now, patients who are on multiple OADs, who are on this multiple OADs, they still do not have a proper A1C control. And where are the insulin initiation done? This is a study published by Kunti et al., where you saw somewhere around when the HbA1c almost about 9%, only then they think of insulin. At say 7, 8, or 9, and so on. When 22% are at A1C of about 10%. So clinical inertia exists despite the benefits of timely glycemic control. Guidelines are encouraging earlier use of insulin. We have the RSCGI guidelines, ADA guidelines, EASD guidelines. Almost all of these guidelines recommend early initiation, and average A1C when the initiation was done was somewhere around 9%. Okay, so none of us think of insulin before that. Now, the fear of hypoglycemia definitely is one of the biggest barriers for insulin initiation. And but this is kind of now these days with the better insulins available and so on, and better regimes being advised to the patient, the fear has definitely, with better awareness, better education, and better monitoring devices and so on, the fear has definitely come down. So when we say hypoglycemia, we'll divide it into nocturnal hypoglycemia, diurnal hypoglycemia, and of course severe hypoglycemia and non-severe hypoglycemia. When we say severe hypoglycemia, needing effort for you needing assistance to control the hypoglycemia. When it is non-severe, symptomatic hypoglycemia, but do not need assistance, they are able to go and take in some food or carb intake, which will adjust the hypoglycemia. So you can see here in type 1 and type 2 diabetes, even type 2 diabetes, type 1 is you can understand because they are on they're dependent on insulin, and there will be variation as per their lifestyle changes. But type 2, they're going to have a baseline of OHA, on top they're having insulin. So that's when still the risk of hypoglycemia being pretty high, especially severe hypoglycemia. So it means that the management of insulin or the dosage adjustment has to be much better, or better insulin should be sought after in these patients, because 58% of patients had severe hypoglycemia and 43% in type 2 diabetic had non-severe hypoglycemia. Significantly lower treatment satisfaction and is a barrier to adherence. You would have seen, in type 2 diabetes, especially once they get a hypoglycemia, they will quietly stop the insulin and come. You cannot convince some of them, because it is really a nightmare for many of the patients when they experience hypoglycemia. So this is actually a very interesting study. Almost around 8 countries this was done in, and almost around 600 600 physicians, 1,250 primary care physicians were looked into, 600 physicians and 600 specialists, 620 somewhere around that were looked into. China, France, Japan, Germany, Spain, Turkey, UK, and USA. Almost 8 countries were looked into, and they looked at the from their data. They looked at from their data, and they got plotted out this. So taking insulin frequently was around 58.5%. Changing timing of insulin to meet the daily need, 57.7%. Taking insulin at the prescribed time or with meals every day, 54%. And blindly following the HTP instructions were 45%, and preparing injections were 35%. So they think 58.5% of physicians think that their typical patients find it difficult to take insulin frequently. So that comes the adherence and barriers. So where is the root cause of it? Where is the real problem? Because insulin per se has a complex, multiple and complex regimen, the fear of weight gain, communication, especially in a scenario like India, where you will have to, the average, one of the papers they say, the average time of diabetologist or a physician spends with the patient is around 3 minutes. That's the average time around India. So within 3 to 5 minutes is the average time per patient, I believe. So within 3 to 5 minutes, how much can you explain about insulin? In some of the tertiary centers, we have the privilege of diabetes educators and so on. Not everybody has that privilege. So in that, you will definitely tend to, miss out on certain important, information, or there will definitely be some doubts and barriers in the patient mind which will be left unclarified and so on. We have a lot of funny stories and all where patient did not take the remove the cap of the insulin pen and kept injecting, and we were like worried of how come the insulin, is not bringing down the sugar. So many things, giving at different places, giving at at the back, giving behind the arm. So communication is very important in terms of educating for insulin initiation. Cost factor is also there when you think of the the best of the analog insulins and so on. It is a day-to-day cost. So you might think of it only at a one-time purchase, but it is a day-to-day cost and a lifelong cost for many of the patients. So that will definitely have an impact, and they're going to think twice whether it is really cost effective to take the injection. And the perceived lack of efficacy. And sometimes when you do not give, in fear of hypoglycemia, do not give the ideal dose, then probably they might think, I am pricking every day and yet my sugars are pretty bad. So why the hell should I prick myself every day? That kind of barriers also do set in. Now, when you look at this paper by Donnelly et al., where we looked at the adherence of insulin therapy, we might think that the higher the dose is going to be much difficult. It is not. The adherence was best with the higher dose, 70 to 80 percentage of dose were taken with, they had a good adherence. But whereas there was a poor adherence with 10 to 20, 20 to 30, with the adherence level of mean of being 70.6 SD across the number of patients, appears poor in type 1, and there was a significant relation between the adherence and the long-term metabolic control. Now, this is again data taken from the EMR data, where the adherence is inversely proportional to the frequency of dosage. So once daily, twice daily, 3 times and 4 times. So obviously the medication schedule being more and more complex is going to be, they'll definitely skip out one of the doses, especially when you give a basal bolus, the noon dose is kind of almost always neglected, or the nighttime dose of the short acting or the rapid acting insulin is forgotten. Only the morning and the night basal is taken. So that can happen when you give a complex regime. Remember, I'm talking about type 2 diabetic population. So they're going to have a OHA also, and they're not tuned in from the beginning about insulin and all that. Whereas type 1, that from the minute they get diagnosed, from the minute they walk in, you're talking to them, explaining to them about insulin. So their adherence, their compliance is going to be totally different. But whereas in type 2, the concept of insulin itself is going to be a big shock on them, and then it's somewhere in between which we are going to push in. So that's why the adherence is also a big problem. The adherence is inversely proportional to the number of doses or the frequency of dosage. And it definitely, the adherence to medication has a huge impact. So this is a study done by Rosenfeld et al., and which is a comparison of if the patient just followed the advice, whatever the physician or the diabetologist has advised, best of the medicine or not the optimal levels which is needed for the patient, yet correcting for all the confounding factors which is just following, almost around 0.34% of A1C reduction can be seen just by following the doctor's advice, So that much is the impact of the compliance or adherence to medication. So we can see the increase in A1C, 2.1 meal related injection 2.1, and 39% of all injection 1.2, almost 0.34% just by adherence. I'm talking about even after correcting for everything else, 0.34% improvement is seen. So what happened, that is with the adherence. What happens with non-adherence? So non-adherence definitely leads on to multiple complications, be it morbidity or mortality. So all-cause hospitalization increases with non-adherent population because there's going to be ups and downs. The patient comes back with hyperglycemia, you up titrate the dose, and then again comes back with hypoglycemia, you down titrate it. Now this is again a biggest barrier, because if they do not following the dosage, you are taking a much prolonged time to control. But thanks to the ambulatory glucose profiles or the SMBGs and all that, it kind of makes things a little simpler, but still unless until the patient open up and getting involved. So unless you have the full cooperation of the patient, is very difficult to treat insulinize a patient. So again, all-cause mortality also increases, be it cardiovascular or non-cardiovascular. Mortality increases in the non-adherent population by almost around 3%, 3 to 4% increase in the all-cause mortality, and again a 3 to 2% increase in the all-cause hospitalization when the patient does not adhere to treatment insulinization. So what did we learn from? We said this is the problem, this is what can happen, and what are we going to do for that? How will we break this therapeutic inertia? So breaking the therapeutic inertia is very important. You have to hit the target immediately and hit it hard. So you have to start with the diet and exercise, and then you wait, there is an improvement, then there's a peak, then you start OAD, then there is an improvement, then again you look at all these upward trends. So these are areas of hyperglycemia. So they are almost when he's able to reduce it, and then a period of hyperglycemia. Then is a optimal control, then hyperglycemia. Optimal control, then hyperglycemia. So there are intermittently lot of periods of hyperglycemia. Then you keep adding one after the other. So this stepwise pattern, one drug not working fine, next drug not working fine, next drug, totally taken off from even the newest ADA guidelines. You look at this thing, hit the target hard, bring it to complete normalcy, and then if needed, down titrate or maintain it at that level. That is the approach you'll have to do, because the negative legacy impact can have a huge detrimental impact on our patient life on the later on. So that is why it is very important that we move the target to a better control from the beginning, and try to maintain it at less than 7 throughout our treatment period for the diabetic population. So getting the glycemic goal early lead to better outcomes in people with diabetes. I did in cohort studies almost starting from the UK periods, DCCT, to all the recent ones with the HLA2 inhibitor trials, and all that have shown that earlier better control has a very positive legacy impact on this. And this is being recommended by almost all the guidelines and all the ADA, EASD, and all the AACE, all the guidelines are recommending, even our own RSSDI, because we might think, yeah, US, UK, and all those places, they're going to be insurance sponsored insulinization and so on. So what about India, when it is from the pocket? And we always had a different spectrum of diabetic population in our country. Even then, the RSSDI guideline recommend that at the max go up to 3 OADs. Don't wait to add on another 4th or so on. But again, this is for clinical discretion. I have so many of my patients where first and second OAD, then I initiate insulin, bring it down temporarily at least, and then go back to OADs alone, or who continue with the second OAD and insulin, basal insulin alone. So it is for our clinical discretion, but we have to think of at least by the 3rd OAD, when you find it not under control, don't wait for the 4th and 5th and so on till you bring it. You have to convince the patient, however huge the barrier for the patient is, however the mental barrier is for the patient, we call it the diabetic distress or the insulin distress. However, it is our duty to address that and give the best of the treatment for this group of patients. So the practical solution to overcome this barrier to insulin therapy is to explain to them the fear of injection. So you can think of needles are small and very fine. Do a demo in front of the patient. Just show them, open up, show the needle size. They might be thinking of the bigger needles, the older one, where injections mean they might be still thinking about, vaccines and so on, where they use a bigger needle. Because so you show them the needles, don't assume, show it to them, and show the ease of the pressure when you're pressing. less painful than fingertips used for SMBG. Why is it less painful? Because the fingertips have more nerve endings, that is more painful, whereas the thigh and the abdomen have less nerve endings and definitely will be much less painful than the finger prick. Introduce insulin pens in clinical practice, addressing injection concern by demonstrating the actual injection process. And the long-acting insulins are easily administered at best time. So you can think of simple regimes like the only basal regime along with OHS. We're talking about type 2, right? So you can usually adjust with the armamentarium being flooded with so many newer drugs. You can think of, adjusting the OHA and the insulin in such a way that gives a smooth physiological, trying to mimic the physiological profile. So long-acting insulin pens make administration easier, and they can carry it also. It's so simple, like a normal pen. They can carry it everywhere. They can keep it outside, except on a very hot sunny day. Other than that, they can keep it outside. You don't need to really take an ice pack and so on for a day or so. The ease of transportation and ease of usage will definitely help to improve the adherence to insulinization. What about the fear of weight gain? You can quote them all these studies which have looked into weight gain, which is much less with the conventional one. Use of anti-hypoglycemic therapies that can attenuate weight gain. You can think of SGLT2 inhibitors or GLP-1 analogs. There are oral GLP-1 and analogs also, or the injectable one. So when you use it, judiciously in a combination, the weight gain can definitely be defeated. And lifestyle modification, which should definitely be part of any diabetic management. So teach them ways of diet and exercise so that their weight gain is minimized. And fear of hypoglycemia. So start slow, adjust the dosage, check the need of insulin, look at the A1C. Probably you can calculate the TDD, total dosage requirement, do an insulin sensitizing levels, and so this can all help in adjusting an ideal dose. Put them on some monitoring devices so that they come back with a log, and then you can adjust from there on. So novel insulin formations usually have the basal insulin. Newer basal insulins have a less hypoglycemia, and thereby hypoglycemia can be avoided. This is the cloud of putting it all together. You can see in the cloud predominantly taking time to explain, educating the patient about insulinization will defeat a lot of their doubts and ambiguities associated with insulin initiation. So addressing injection concern, talk to them directly. I ask direct questions like, why don't you want insulin? What is the problem with insulin? What will happen if you take insulin? You can ask them questions like that. Let them open up and then address each of their fears and explaining the benefits of insulin. So after they've done that, you can talk to them about how why am I giving you this, and what am I expecting from giving insulin, and what will be the positive impact of insulin. And of course, adopting a collaborative communication style. So as I earlier also mentioned, unless until the patient is involved with the regime, that is for every patient, even without insulin, you have an involved patient, definitely the results are better. But with insulin, it's much more. Unless until the patient is involved in the process, he is completely, comfortable with a conversation with a physician, I don't think this is going to be positive. So I would stop here with thank you all for all your patient listening, and any questions I'll be happy to take. Thank you. I can't hear you. Dr. Amarjit, I can't hear you.
Thanks, Dr. Rudra, for your vibrant and remarkable presentation. Now the floor is open for question answer. So if any question will come from audience, if anyone is interested to ask. So Dr. Rudra is here. I think we received one question. You can, Doctor, you can see on chat box. Question from Dr. Rashan Yadav.
I can read it here. Question from Dr. Rashan Yadav. How to avoid the inconvenience of initiating insulin therapy in patient. Yeah, again, that's the biggest challenge here, because until I am convinced it is not an inconvenience, I'm not going to be convincing my patient. So when we see the pens and all that, which are newer technologies with the smaller needles, I think we have to weigh the pros and cons of insulinization. So when we feel definitely the patient will benefit with insulin, when we are convinced about that, we will be definitely able to convince a patient. So you can explain to them nothing that if I have to give a one-word answer for this question, it should be education. Okay, so you have to educate the patient, talk to them, as I said, or ask them to open up about their fears, ask them what are you worried about, you think it will be painful or so on. In front of, sometimes the patient will say, oh no, I'm scared of injection since my birth, I don't take any injection, I didn't even take my vaccination. There are patients like that who would definitely benefit with insulin. Then we do a demo of the injection. They definitely would have a high dose, so we try to give them just 3 units or 4 units right away in front of us, when they can feel comfortable that nothing is happening and it's just a small prick and so on. And we can definitely compare it with the SMBG pricks, which most of our diabetic population are now aware of and are doing in once in a while. So we can compare this and say it's much less than that.
So we are waiting. No question on the chat or no raise hand.
Ma'am, thank you for such a wonderful oration. One question, I mean, you projected a slide that currently in RSSDI even guidelines have suggested that with newer antibiotics with basal insulin. What's your take on that? I mean, does that make it initiation and even handling all the complication much better?
So I thank you, Dr. Kunal, for that kind words and the question. I understand your question has two parts. One is that because of the newer OHA has insulinization been a little less, and the second thing is we're able to get a better control because of OHAs and insulin. Is that right? So if for both the parts, I would say yes, with the newer medications and all that, yeah. But how we go about is that even the ADA guideline clearly says that if you have a very high HbA1c, for example, you have an A1C of above 8 or above 10. Most of the time, when you think of two parts, about 10, then the first thing that comes to my mind is that break the glucotoxicity, bring it to normalcy. So probably a temporary period of basal insulin along with OHAs, I would think, even in a naive patient, depending on the complications and so on, if they are coming in with complications so on. About 8 A1C and a naive patient, newly diagnosed diabetic, probably you can think of OHAs and then see the response, and then think if they do not have any complication, think of insulinization. Yes, the newer OHAs have definitely been useful in bringing down the glycemic levels compared to the earlier one. But all having said all that, insulin in 100 years have never lost its charm until the prescribing. If you look at the prescribing this is only increasing. It has not got down. The insulin initiation had not got down the number of insulin in type 2 I'm talking. Hasn't come down or anything. We have understanding the concept of temporary insulinization, early initiation, and better glycemic control on an earlier. And according to our discretion, use the insulin.
Thank you, ma'am, for that answer. And definitely, ma'am, it's really the topic as it is, barriers, what we feel. And ma'am, with my conversation, and as you have worked with Mohan sir, he has always been stalwart in early insulinization, and even he has a big diary which talks about when early insulinization, the legacy effect and all that. If you can throw some more light on that, and especially in the patients where only, let's suppose, basal insulin has been initiated early in the diagnosis, and how it has change the outcome of the patient, that because one of the most common barrier is like, is it lifelong?
Yeah, that is usually the common question. I did tell that habit forming. They think once you start insulin, it will become a habit. something like, they think it is like a bad habit and so on. Yeah, that is a difficult thing to answer because most of the time, you can't clearly, I do tell them, you will take it temporarily. I do a C-peptide level. They have a very good pancreatic beta cell reserve. Most of the time, they would not need it on a long term. So they would definitely need it temporarily, provided you use the right choice of OHAs, and they also have a good adherence to lifestyle modification also. Especially in the naive patient, early initiation naive patient is very easy. You know that, right? When they come with very high blood sugar and initially they're coming in, anything works. So almost every medication will work in a naive patient, not on any medication patient. But it's only difficult when a long-term patient who is already on like 3 or 4 OHA, you're thinking of with the end of secondary OHA failure. At that period, you're initiating insulin. And that time, probably the temporary insulin cannot be other. But for them also, I do say, this is the need of insulin you need right now, this much dosage you need. You bring down the level. If you're able to maintain your glycemic control less than 7 and so on, we'll definitely think of reducing your dosage. If you're doing even better, we can even cut it off, depending on your glycemic control. So give them targets, so work with them. So you are already experienced, so you might already have your way of convincing. But with me, what I do is I try to involve them. I tell them, you bring it below 7, we'll start reducing, and slowly, we might be able to stop it or not. Sometimes we might not be able to, but at least the patient does understand, that this is where we are working on, this is where we are trying to reach, this is what we are aiming at, and so on. So problem comes only when they're not convinced. Less than 7 is the ideal HbA1c, when they're like, so what if I have 300? Then that group of patient is what is little difficult to handle. Even then we tell them about, microalbuminuria or, retinopathy or something. People who have been having a very high blood sugar definitely will have few complications. So complete workup of a patient at least once in a while could help you, make them about fear, create little fear about adherence and so on.
Thank you, ma'am. And ma'am, you presented a slide of your center itself, in diabetes care study, and what the prevalence we used to think and what exactly it is. And in such a scenario, how important is the role of insulins in terms of the growing, the overall what we see is the menace of diabetes that we see currently today. I know you have addressed it in your last 2 questions, but these numbers are really staggering. So, and I know you have been part of it, it's from your center itself. So can you just throw some light on itself that, yeah, we know, and you have also addressed the point that if it is a simple regime, it makes more sense, it makes more adherence with the newer antibiotics, antidiabetics. So how do you see it shaping up, not being the diabetes capital of the world, but being the diabetes control capital of the world?
Yeah. So this is exactly like, I like the word menace. Yeah, diabetes menace. That's a good one to put it. Now, even sir, you keep telling, we might become the diabetes capital of the world, BM sir will say, but hopefully we won't become the diabetes complication capital. So we try to take away the complication. Let people have diabetes, but be able to control it. So that's what we're aiming at, because we cannot really cut down the number. So it is going to increase. We're going to have more and more diabetic population. But at least if they're able to keep it below 7 and they have no complication, they're able to handle the diabetes, that should be fine and fair enough. But like you said, the INDAP study, almost around 22 states and union territories were looked into. And the sad part is almost 90% were from tertiary centers. So we collaborated with many of the other doctors from many of the other states, Nagpur, Pune, so many places. And the sad part is all of them are already diagnosed diabetic population, and yet they have an average A1C of 9.5. It is not like the newly diagnosed. It is not like a epidemiological study where we go screen all the population and we find 9 and 10 A1C. It's not like that. These are all who are aware they are diabetic. They are consulting at some time in their lifetime. They had consulted diabetologist or a physician or someone. So they are quite aware of the situation, and yet they have a 9.5 A1C with all the access to treatment and so on. So that's, so much is lagging behind in terms of, awareness and so on. Of course, as I did mention, there are so many barriers, cost barrier, cost effectiveness of each medicine. Patients are not convinced about the cost effectiveness of expensive medications and so on. We are convinced because we look at, this study says 35% reduction in MI, this study says 42% reduction in CAD risk and all that we get convinced. But as for a patient, I say 32% reduction in MI, he say, okay, fine. So what about the other 70%? They are fine, right? That's the kind of concept they're going to have. So each one size does not fit all. So each one we have to have. But the only thing is when they have looking at the patient sitting in front of us, when look at all their complications. So usually very poor control for a long term, as I did mention, they'll have some complication or other. So work on that, build up on that, and then you can explain to the patient, or they would have a family history of some complications. We can pick up on it. But as you asked in your question, how are we looking at in long term about it? The numbers can't be brought down, but at least the average glycemic control, if we're able to make it at 7.5 or something, if we can, that's the doable number. I think if you, me, all of us work together, should be possible.
Yes, definitely, ma'am. We are just awaiting the question, and meanwhile, we'll keep the ball rolling. And ma'am, definitely you said the latest study says that average HbA1c based on the 22 states and the union territories is more than 9.5%. If you look at the guidelines, they definitely suggest if it is more than 9 or 10 based on different guidelines, insulin should be initiated.
Yes, yes.
Yet we are not there. So what will be your message to all the almost 700 odd healthcare professionals, those who have joined with us, as to how to handle this situation?
Yeah, so I think, as I did always mention, when a new drug comes into the market or a new insulin comes into the market, first I have to be convinced that will be beneficial to the patient. So I think if I am like 100% convinced this patient will benefit with insulin and I am doing complete justice to this patient, leaving out all other factors, you work in a corporate, you have 15 other patients waiting outside, or leaving all that, if I'm really going to help this patient in a long run, preventing his complications, improving his quality of life, even after giving him insulin, I think we'll be able to convince the patient. But maybe not in one visit. And one more thing is that most of the time earlier, nowadays, I don't think any of us are doing it, hopefully. But earlier, it was used as a terror tool, okay, you don't work out, you don't do a lifestyle, I'll think of insulin in the next visit. Something like that. It was always a trend. Even children, they will take you to the doctor, they'll put you on injection. They fear doctor means the injection, doctor injection, that kind of concept all through from childhood, it has been there. So that has to slowly change, even the social wise, how these pharma people and all them are really doing a huge role in, evading that stigma of injections are bad or something, the worst last scenario and so on. So they are trying their best and we're also doing it. So start the conversation quite early. I think when a patient comes in, he might or might not need insulin, but then you can tell them, these are the choices, these are the options available. So right now we will go with this option. So these are the rest of the thing. I would think of it maybe eventually little bit, maybe if it is not as per the plan we are doing. So that time I might think of insulin or so on. And then we can get back to OHAs, or if that's the best choice for you, we will do that. So start the conversation early. Don't keep insulin as a threatening factor or a last resort or so on. So once it comes in the conversation, they might not need it lifelong also, or they might need it somewhere in between. Then it will be very simple for them. They are already tuned to it, and so they'll be happy with your choice of medication.
Thank you so much, ma'am. It has been really enlightening and insightful. And now I'll hand it over to Dr. Amarjeet and Mr. Vishwa for the rest of the.
Thank you, Kunal. Thank you for that, Dr. Kunal, for that wonderful interaction. There's one more question, if I'm not wrong, from Dr. Nirmala, I think. How about adding insulin with type 2 diabetes patient? How it benefits in the long run? Yeah, the whole presentation was about type 2 diabetic. So there's no, at least all of us are 100% convinced about type 1 diabetes. So in type 2, only early initiation, the whole conversation definitely in the long run, maybe not all patients, not all of our patients type 2 diabetic would need insulin, but there are a few who would definitely benefit with either temporary insulinization or a long-term insulinization also. Don't wait till secondary OHA failure and then think of insulin in the diabetic population. So look at the trend, look at how their glycemic control and start initiating early itself. And as I said earlier, a question also, as we discussed with Dr. Kunal, start the conversation early. Let that concept of only insulin is only for type 1 and not for type 2 go away when we are discussing with our patients. And as far as we put it in one word answer, good glycemic control is what we aim at. So if you want good glycemic control all through, optimal control all through, if you're able to do with minimal OHA, well and good. If you're not able to do it with minimal OHA, think of other choices and let that not be second, third, fourth, fifth OHA. Think of insulin earlier.
Thank you for that answer, ma'am. Now keeping time in proximity, one last question, a very simple question. When should we initiate insulin when we see an HbA1c more than 9%? If it is 1 OHA not doing the job, 2, 3, 4, what will be your take?
Yeah, that's like I usually have a presentation, for the fellows or students. So like that $1 million question: when to initiate insulin? It's really $1 million question, because the scenario is so varied. Diabetes is such a heterogeneous disease, type 2 diabetes. So you cannot really say one word answers, no MCQ choices of which one and all that. Because at 8 A1C, I have patients who initiate insulin. At 10, not initiating insulin. So it's so much varied. So I would say in general, if you have for a learning perspective or for an exam answer point of view, if the A1C is above 8, that should come to your mind, but not necessary you have to initiate it. Look at the comorbidities or the complications of diabetes, the duration of diabetes. If you can, please do the C-peptide. If you have access to it, you can do the C-peptide levels, and that could aid you to a certain extent. If not, also the complications risk, the duration of diabetes and the duration of poor glycemic control and the OHA history. So they're already on 2 OHA, 3 OHA, and there's no point in the 4th and the 5th. I showed you, why did I show you that slide? How much is the A1C reduction? 0.7, 0.5, 0.3. So with 1 OHA, you had a 0.7. Then the second OHA, 0.3. And all this when they were named. So you're using only that OHA, 0.7. So on top of another OHA, you won't get another 0.7. You're not going to get, a much more higher A1.14% reduction. You won't get. On top of 0.7, you might get even only a 0.3 or a 0.4% reduction when you add the second or the third drug. So you want something. So look at it. If it is 9 and 10, you want a drastic drop down. None of the OHAs are going to bring it less than 1.5 or less than 3.5. So you have a 9, you're aiming at 7. So that is where when you want a rapid reduction, you want to bring it to less than 7 quite rapidly, and you want to do it earlier, then insulin would be your ideal choice.
Thank you so much, ma'am. And definitely it was like clinical pearls of wisdom for all our attendees.
Thank you.
And yes, as you rightly said, hit early, hit hard in crux. Thank you so much, ma'am. It was really, I think it was, we are really grateful for all the insights that we got. And I'll hand it over to Dr. Amarjeet and Mr. Vishwa for the proceedings. Over to you, guys.
Thanks, Dr. Kunal. Now I would like to call our marketing head, Mr. Vishwa, for the vote of thanks. Over to you, sir.
Thank you, Dr. Amarjeet. Before I start, I would like to share something because I have a great news to share with you all. That we are having India's first recombinant human insulin, and I am pleased to announce that this year we are going to complete 20 years. Wosulin is going to complete 20 years, and this year we are celebrating 20 years of Wosulin. In 2003, we launched Wosulin and put India on the global map of insulin manufacturers. Before India, insulin were produced only in USA and Europe, and India became the 3rd country in the world and 1st country in the Asia to start producing Wosulin. And human insulin was at that time manufactured at our Aurangabad site, which was inaugurated by Dr. APJ Abdul Kalam. So thank you very much to the medical fraternity for bringing the glory to the Woselin and supporting Woselin so that he can complete 20 years. Thank you very much. And so in Wockhardt iTrust webinar, it is my privilege to extend a heartfelt vote of thanks to all of those who have made this event a resounding success. And I would like to begin by expressing my deepest appreciation to Dr. Putra ma'am for her insightful and thought-provoking presentation. Her expertise and knowledge have enlightened us on a subject of utmost importance, and I'm truly grateful for her valuable contribution. I also would like to express my heartfelt appreciation to all the delegates who have attended this webinar. Your participation have added immense value to this gathering. I extend my sincere thanks to Dr. Amarjeet for his exceptional moderation skills throughout the webinar. And I also thank Dr. Sanket and Dr. Kunal for powering iTrust webinar scientifically. A special mention goes to our IBB President, Mr. Amrit Medigar sir, for his vision and leadership that have made this webinar possible. And my gratitude extends to LCS Sri Vishnu sir, who is a cluster head of diabetes business, for his support and guidance in organizing this webinar. His dedication to promoting knowledge sharing has been instrumental in making this event a resounding success. Lastly, I would also like to express my gratitude to Diabetes Division field team and all my HO colleagues, especially Mr. Ninad Parekh and Mr. Nirmal Panchal, who is sales head of Diabetes Division, who have worked very hard, who worked tirelessly behind the scenes to ensure the smooth execution of this webinar. Concluding here, thank you all once again, and we look forward to your continued support for Wockhardt iTrust webinar. Signing off, thank you very much.
Thank you. Thank you to all.
Thank you, Wockhardt. Thank you all. Bye-bye. Have a great night.